Hi, and welcome to our presentation on our report on addiction services in Northern Ireland. Today I want to talk through both why we chose this topic and what we find in our audit. So, why addiction services? Well, firstly, and most importantly, these are services that provide treatment for some of the most vulnerable individuals in society. Addiction itself is an incredibly complicated disease, so it's vital these services are providing value for money. Alongside that, the Department of Health have overall responsibility for strategy in this area. The strategy is now well out of date. It ran out in 2016 and a successor hasn't yet been published. So there's a real opportunity for us to add value at a time when the department are designing their new strategy. So that's the why. Let me move on to what we found during our audit. And I'll start with a very high level summary distilled down to three key issues. We find the level of harm caused by substance misuse in Northern Ireland is high and rising. Despite significant costs related to substance misuse, a small budget is allocated to tackling the issue. And finally, despite these high levels of harm and significant costs, the department has little information on the outcomes for service users. So let me unpack that a little, and I'll start with costs. Human costs, financial costs, and costs impacting right across the economy. Firstly, human costs. And in many ways, whilst we default to numbers and graphs, that can never tell the full story of human costs. Each of those numbers is a person with a human story, and addiction therefore has a huge impact on them, their family, and the community they live in. So whilst we struggle to capture the real impact, what we can see is that the numbers of those suffering are increasing. The number of drug-related deaths have more than tripled in a decade. Alcohol deaths have also increased over that period. And this is affecting disproportionately those in the most deprived areas. In Belfast, for example, drug and alcohol death rates are 4.5 times higher in the most deprived areas than rates in the least deprived. That's a huge difference over what can be quite a small geographical area. The financial costs related to substance misuse are also significant. The latest estimate, and this is just for alcohol, is that misuse costs up to £900 million per annum. Add in drug abuse, and those costs are likely to be over £1 billion. And as we said earlier, these costs fall right across the economy. Around a quarter of those costs fall directly on the health and social care sector. But there are also significant impacts on criminal justice and the wider economy. And those health costs are often just picking up the pieces, not addressing the issues themselves. Estimates are that a quarter of A&E attendances could relate to alcohol alone, a cost of £33 million per annum. Around 14,000 admissions to hospital were related to conditions wholly attributable to alcohol or drugs, an estimated cost of £23 million per annum. And 73,000 hospital bed days in 2017-18 related to substance misuse. That's 200 beds each and every day, almost the equivalent of a full Mater hospital. So given how large these costs are and how broadly they fall, we believe there's scope to make significant savings. However, currently services to directly tackle substance misuse only receive £16 million a year. That's a fraction of the costs, and only a fraction, at around 5%, of the mental health budget. So, the department spends £16 million in addiction services. But our audit work found they didn't know what impact this was having, didn't know what difference services were making to service users, or how effective they were. Information was collected in the substance misuse database. This was set up by the department to collect data on those seeking treatment, but was only published once for 2016-17. Since then, the data collected hasn't been of good enough quality to publish it as an official statistic. Even without these quality issues, though, the information collected by the department is largely activity-based, just recording the numbers of service users who enter treatment. This is in contrast to elsewhere in the UK. It means that the department have little information on the outcomes of treatment, and we have a few recommendations in this area. So given that level of funding and given the rising level of demand, it'll come as no surprise that services are struggling. The ministerial target is that service users should be seen by services no more than 9 weeks after being referred. That target's already much longer than elsewhere in the UK, where it's 3 or 4 weeks. But despite this, there have been significant difficulties in some trust areas. A huge peak in Belfast in 2017, a smaller peak in the Southern Trust in 2018. And at any one time, there were around 1,000 people waiting for the first appointment. Now, we're used to waiting lists in health, but clearly, when someone seeks help for an addiction, having to wait for a significant length of time for an initial appointment is likely to reduce their chances of a successful recovery. Demand's especially high for substitute prescribing. Substitute prescribing replaces opioid drugs, often heroin, with a safer opioid. A spike in demand in Belfast caused waiting lists to rise to 57 weeks by late 2017. So those are people who had sought help for a heroin addiction, presenting themselves to services, being ready to come off drugs, being told to wait over a year for a first appointment. Whilst this is now stabilised, Belfast Trust told us referrals had increased by around 300% in just the last year. So, another challenge facing services is the increasing complexity of those who present for treatment. Alcohol remains the most significant substance issue in Northern Ireland, and alcohol-specific death rates in Northern Ireland are the second highest in the UK, significantly above England and Wales. But whilst rates elsewhere have increased only marginally in the last 5 years, they're increasing substantially faster in Northern Ireland, indicating a growing problem. Alongside that, those who do present with substance issues increasingly are presenting with polydrug misuse, using multiple substances, including alcohol, and that's making treatment much harder. We've recommended that the new strategy considers these complexities to ensure services are designed to cope with them. Another issue that's particularly prevalent in Northern Ireland is the misuse of prescription drugs. In Northern Ireland, the majority of drug-related deaths now involve prescription drugs, and the two most common drugs mentioned on death certificates are tramadol and diazepam. But there's also been a big increase in the number of pregabalin-related deaths in the last 5 years. All of these drugs are available on prescription. So it's clear these drugs are causing a significant amount of harm in Northern Ireland. And whilst they can be obtained from a number of sources, both legally and illegally, during our audit, we looked at prescribing rates for these specific drugs. So for diazepam, there are 3.5 times as many prescriptions per capita for diazepam in Northern Ireland as in England. Likewise, despite guidance from the Health and Social Care Board, tramadol is prescribed much more frequently in Northern Ireland than other parts of the UK. And it's a similar story with pregabalin. Northern Ireland has the highest rate of pregabalin prescribing in the UK, and the number of prescriptions are increasing year on year. This again is despite advice from the Health and Social Care Board, which was given in late 2012. Further advice was sent in 2016, but despite this, the number of prescriptions continue to rise. The irony here, of course, is that public money is paying both to prescribe the drugs and to deal with many of the consequences of the increasing use of these drugs. So, this is clearly an important topic, not just financially, but more importantly for helping to improve services for those who need it most. It's also an important time. Demands are increasing, care is increasingly complex, and the department are developing a new strategy. I finished back where we started, this time with C&AG's take on those 3 key messages, highlighting that a joined-up approach across the whole of government is needed to tackle this issue, highlighting this is an increasingly unsustainable burden, and that the future focus for services must be on the impact they're having on people's lives. Thank you.